back to another episode of the Venous and Lymphatic Forum. We are broadcasting live from the Houston Methodist Hospital, the DeBakey CV Live Studios in Houston, Texas. I am Ulises Baltazar, and I am your host. Today we are going to have some case presentation. I'm waiting for my partner, Dr. Jean Bismuth. Should be here any minute. He had some last minute case, and I understand he's parking, so he'll be here in a few minutes. He always has great insight about our cases, and he has tremendous experience in endovascular procedures. So we are going to wait for him. But anyway, in the meantime, I'd like to remind you that if during this streaming you have any questions, any comments, to contact us, feel free to contact us through all those platforms that you can see in your screen right now. At the end of the show, whatever questions or comments we will address if the time permits. But that's the whole idea of this type of platform, to have an interaction in this virtual world that somehow we are learning to navigate nowadays. So it is important to keep the exchange of comments, questions, answers, knowledge, because that is what makes us grow as not only as physicians or surgeons, or as a person. So, but anyway, so today we are going to review some cases. So I have two cases, and in the meantime, John gets here. So we are going to start with this first case. And not everything is easy and straightforward, and that's the objective of this type of presentations. The typical cases, the straightforward cases, you can read them in a book. That's not a problem. This is when you need to start exercising the knowledge that you have as a physician, and you know, train your criteria to make the best possible decision for your patient. So let's start with the first. The first is a 48-year-old male that came to my office with about 3 to 4 week history of right leg painful edema. Now, this edema was involving the entire leg, all the way from the groin to the foot, and was intermittent, on and off. It is not constant, and that was a little bit puzzling. Few days before he came to my office, he had a history. Oh, there is. Here comes my partner in crime, Dr. Jean Bismuth. So, Jean, I'm presenting the case of a 48-year-old gentleman that came to my office that you were involved with a few weeks ago. You helped me taking care of this patient. He had came to my office with history of 3 to 4 weeks swelling in the right lower extremity that was involving all the way from the groin to his foot. This edema was intermittent, as I said, disappeared in the morning and was present during the day. And firsthand you'll think this is a vein case, right? I mean, the swelling almost goes with the vein presentation that gets worse throughout the day. Few days before he came to my office, I was mentioning he had some shortness of breath and some chest pain, and went to the ER, had an ultrasound which was negative for deep venous thrombosis, and then had a CTA. For all those that are not familiar with those letters, is a computer tomography with contrast, and with a PE protocol for pulmonary embolism protocol. Yes. Welcome, Jean.
Thank you.
That's okay, man. I explained to our audience that you had a late case, so I'm grateful that you made it. Then you make it.
And then, of course, we had the wonderful Houston traffic, which is,
I know.
It is what it is.
It is what it is, man. I'm telling you. But listen,
thanks again for having me. It's it was fun last time, and I'm sure this will be just as much fun as it was the first time.
Well, I'm grateful that you can help us with this kind of presentations with your experience. So, as I was saying, this patient had a CT to rule out pulmonary embolism, was negative for that problem. So, there was any typical or important history that triggered the swelling of the right lower extremity of his symptoms. He had history of some varicocele. He wasn't sure which side was present a number of years back. Mild spondylosis of the lumbar spine that was causing also some leg pain, and recently started having some problem on his neck and left upper extremity. He had an MRI of the cervical spine, and after the study he had this unusual reaction with the hypertension, headache, malaise, and of course, was managed as in some reaction to the contrast, to the gadolinium, resolved with hydration. So when he came to see me, we did order a venous reflex duplex ultrasound. The results are there, and as you can see, the reflux time in the superficial system, what you are looking there is just the superficial system, right and left leg. We consider reflux time in the superficial veins pathologic when it's more than 500 milliseconds. And it is, below the knee gets to 2 seconds on the right leg, that is the leg in question. But also the peak reflux velocity is increased, especially at the bottom in the ankle, 20.3 centimeters per second, that's quite high. And the diameter as well. We have 8.8 millimeters in diameter in the right lower extremity, right next to the saphenofemoral junction. And on the left is 9.4. Nevertheless, that goes to tell you, you need to, when you see a patient with vein disease, you need to try to put not only the labs together, but also the clinical picture, what the patient is complaining of. So, but seems like a straightforward case, right? I mean, the patient has right lower extremity swelling, but there was something that didn't quite, work in the story. So, because with that ultrasound, you will think, well, why don't you do a greater saphenous vein ablation? Mm-hmm. So we consider that, but again, as I said, with a history of varicocele, he didn't know what side was. The clinical presentation of the swelling wasn't typical of a vein disease. So I said, okay, let's go ahead and what are the alternatives here, right? For the young physicians, when you have a patient like that, well, you have a compression trial, and that's what we start with a thigh high 20 to 30 millimeters of mercury compression, because eventually the compression trial normally will give you some idea what the therapy will do for the patient. If you are going to ablate that vein, this compression will give you a very good idea. So he had a modest improvement. It wasn't that significant, which I don't like generally when that happens. I like to see a very good improvement.
I agree.
So what is the alternative? Go to the ablation, that's always a possibility, or do a CT or a venogram. Well, as a good vascular surgeons, we choose the venogram, and this is what we found. This is posterior tibial vein. I like always access the posterior tibial vein. This is the popliteal vein, and what do you see there? A very narrow popliteal vein, and looks like duplication there, some sort. And this weird branch that people will think might be the greater saphenous vein in more proximal view, like this one, but it's not, because coming direct from the popliteal. Then goes into the common femoral vein, common femoral vein, then into the pelvic area, and here another thing, another image is important to recognize in the external iliac vein with that stenotic vessel. So I always try to complete the whole venogram. The vena cava seems, it's not a great opacification, but it seems clear. So we have this stenotic area in the external iliac vein. So we put IVAS. Unfortunately, and you guys are going to be mad at me, I didn't get those images, but the stenosis was 65-70%. So what do you do here? What do you do with this patient that has swelling that starts all the way from the groin all the way down, that has this venogram that we just saw, in with an IVAS that is 65 to 70% stenotic? First of all, before you give me your opinion, Jean, we need to recognize something. There is no side branches.
Right.
There is no collateral circulation on this vein.
I was going to make that point because that's super important. And I think even when you're sort of teaching the basics of venous physiology,
sure.
If there's stenosis, in general you have collaterals, right?
Right.
So that I agree. That's an important point. I'm happy you brought up the IVUS because I was going to ask you that, and I couldn't remember whether you had done it or not.
Yeah.
I only saw this gentleman after you had actually placed the stent here in the iliac.
Yeah.
And I'll tell you, for the viewers, I was super impressed about his swelling that he had below the knee.
Yeah.
It was not subtle at all. It was very significant, and he was very maligned by it. I mean, it was something that affected his everyday.
Yes.
It's a curious problem. As you know, I'm going to let you go on and present. We had talked about it a bunch, and I certainly asked the opinion of a number of people around the country. What would you do? And I think not to ruin the story, but I think it's important to know that we did a lot of pondering on this case.
Yes, the decisions we made on this case, they were not done lightly. I can tell you that, all the viewers, because I know I'm going to be criticized for what I did next. And I'm sorry, the movie, the things I paused the movie, I didn't let it run because I did put in a stent. I could not ignore that. I know there were not collateral veins there. And let me make one extra point here for all the med students and young doctors there. You can have a stenosis like this that we are looking without any collateral circulation, and in theory is not hemodynamically significant because there is no collateral circulation. But in a patient that starts swelling from the groin down, that is intermittent, that is not all the time, that has a history of a varicocele that he doesn't remember what side, I want to think is the right side. I made the call. We put the stent, and this was the result. Now, I want you to pay attention, young doctors. There is a little narrowing here in the distal part of the stent right here. When you put in a stent that is not properly matched, you might have this and you may panic. But when you properly match in a stent, don't worry about it. And I'm telling you this because we did another venogram, and you'll see how when the spasm goes away and how this looks. So don't panic when you do this. When you see this after you put in a stent, that you have maybe mismatched the device versus the vessel.
And Ulises, just for completeness, what kind of stent did you put here?
I put a Vichy,
okay.
A Vichy, Boston Scientific Vichy 10/90. And as you know, just a side note with the Boston Scientific, some of these devices have been voluntarily recalled by Boston Scientific because there was some issue with migration that they're still in investigation because it seems like the devices were mismatched, the ones that they migrate, they were too small and too short. That's. Do you have any input on that?
No, I don't. Ultimately, I think you and I have talked about it a bunch, and I lean more towards a more compliant stent. There is this notion that you need to make the vein round to be successful. We weren't born with round veins, and so
correct.
But I don't think there's truly enough science behind it. There are some industry-sponsored trials that have shown, good results for both the more stents with more radial force and the more compliant stents. I guess in time we'll see, and hopefully we'll have better information.
I think the beauty of this kind of technology is that it evolves every day. Every day we're finding new physiologic data that will help us model the stents and the technology better. So whatever is true today is not going to be tomorrow.
Correct. And I think one of the humbling things about venous disease is fundamentally, I don't think many people, including myself, really understand the physiology, the flow.
Yeah.
This is arterial flow is very easy.
It seems to be
for the most part.
Yeah.
Anyway.
Yeah. So what happened? Well, he went home. We put him in antiplatelet and anticoagulation, as you can see there, compression stockings. And we encourage, obviously, exercise and weight loss program. And he had excellent progress for 72 hours. And then the swelling came back. And at this point, I start questioning if those lesions in the popliteal area should have been addressed or not. And I invite Dr. Bismuth to help me out here, and he saw the patient, and he agreed that probably we need to do another venogram. So I took him back to the angio suite. Oh, I'm sorry, I'm giving away the secrets here. So I took it to the angio suite, and what happened is, I'm sorry guys, technology. Talking about technology. So it's not going to start. Oh, that's phenomenal. Anyway, this is sad because that video was very good. All right, I don't know why. Anyway, I don't know why it's not playing here. I'll tell you what we are going to do, I'm sorry for this technical difficulty here. Let's try to look at there. So this is the popliteal vein in neutral position, and we can see here the duplicated vein, and this is where plantar flexion. You can see with plantar flexion how some of the vein is occluded, and well, this is the stent. I told you that the spasm was going over there in the distal aspect of the stent. So this is the proximal vein again, neutral position, the popliteal vein, and this is where plantar flexion. So I start thinking about popliteal entrapment syndrome, and we talked to this gentleman in length because it's not an easy surgery, as you already saw that little clip, and we decided to proceed.
So I think you have to, for completeness sake, I think you said it before, we did an MRI to see whether there was any evidence of popliteal entrapment syndrome, and really there was nothing convincing about the MRI.
There wasn't nothing convincing about the MRI about the popliteal entrapment syndrome. Nevertheless, again, the clinical circumstances, they was supporting this, and the patient felt also very strongly that he wanted the treatment because he is really being handicapped by this situation.
Yep.
So the surgery, as you can see here, I don't know, I'm going to leave the original audio. I don't know if you can listen.
Tibial and conperoneal nerves there. And we have looks like a medial genicular branch, the vein here, ultimately coming down to what looks like a duplicated popliteal system. One here that goes anteriorly, and another one that comes posteriorly here. In between those two, you have right here the popliteal arteries. Those are my subvenae. If we follow that up, here is the popliteal artery, now completely released. And we see no muscle coming across it. We see no muscle coming across the vein either. We did see some fibers before. And I think.
But you did see the vein going over the artery, right? And it's wrapping around instead of the regular anatomy.
So if you look at it like this, you see on this side here, you see the two fissures, duplicated systems, you see the artery here, and the vein that wraps down underneath it right there.
So that was the surgery, and this is a close-up of a picture of some of the fibrous bands that we found surrounding some of the popliteal vein that we transected. Obviously, right there in the green arrow, you can see the fibrous band. So it's an extensive surgery. It's not easy to recover from this surgery. The discomfort is quite a bit, but anyway, the patient did well after. Had a mild dehiscence in one of the corners of the incision that is healed now, and the pain wasn't that bad actually. I was very surprised how he progressed in regards of the pain, and we restarted the anticoagulation, antiplatelet. Edema improved, but recurring 4 to 5 days. So this is where we are now, and this is the type of cases that I personally learn more than the straightforward, oh, you do this, you do that, because this is now what? Now what are we going to do with this gentleman, with this patient? And I'm afraid to say, but now we are considering also address the greater saphenous vein. But the greater saphenous vein is not going to give you edema proximally.
Correct.
It's not going to give you edema in the thigh. It's normally from the knee down. All the symptoms are knee down. That, granted, on this gentleman, on this patient, below the knee is where they are the worst. So, you know, it's one of those cliffhangers that I'm going to keep you posted as the next chapter develops. But one thing that I learned personally is try to stay with the patient, because nowadays we are just like, well, I don't know what it is. This is not it. I already opened up all that I could open. I already angioed all that I could angio. Go somewhere else. No, I think we are going to stay put and try to help him and try to find what is the next step.
Yeah, so I think, you know, this last piece of information I didn't have coming into this, as far as you considering ablating the saphenous vein. I would say probably there's nothing to lose by doing it. You know, it would. I imagine you've done a follow-up ultrasound on his popliteal vein.
I did, and it's open. I mean, it has good flow, and the interesting part, and I didn't bring it up here, and I do apologize for that, is that the ultrasound before and after of the popliteal vein doesn't look terribly better afterwards. You know, you will imagine that the flow is wide open.
Right.
It's better, but it's not what you will imagine. So it's one of those cases that makes you. It's a humbling case. It's very humbling
I think
case.
the story's not done yet, right?
No, it's still going on.
Yeah.
It's still going on. So that's the first case. Do you want to present one of yours, Jean? Or?
Sure. I think mine go together.
Okay.
So I would say probably yours, because I think the discussion kind of fits together for my two.
Good deal. So the next case is a 69-year-old female that recently lost weight at the tune of 60 pounds on purpose. She started to getting healthy. And her current weight is 240 pounds, so she was at 300. But when she lost this amount of weight, she noticed a disproportion in size of the left thigh in regards of the right that she's never seen before. And she had lost weight in the past, all the way down to 225 pounds, and she never noticed this. So this is new. How new? We don't know, because she just lost that weight. She also complained of burning sensation around the groin in the inguinal area that radiates towards the hip and towards the leg at the point that she cannot sleep on the left lateral decubitus, because that pressure on that area is uncomfortable for her. So initially, I thought, because the looks of it, the looks of that collection, of that increase in size, that, by the way, is about 4 inches bigger, the left than the right.
I'll tell you something. Yeah, I think I told you on the phone. I think you undersold it. When I saw her, I was pretty impressed by the difference in girth between both thighs in particular, but even her lower leg is bigger.
Correct. Yeah. Correct. So she went somewhere else before came to me, and of course they did a great saphenous vein ablation. I don't know what was the point of that, because this is not typical the way it behaves, with no improvement, of course. She has also history of low back pain, high blood pressure, hypothyroidism, hypercholesterolemia, and also gastroesophageal reflux disease. So with this anatomy that she presented, I thought she could have something that is called bridge pattern lipedema. That is it's a collection of a normal collection of fat that resemble bridges. Doesn't go all the way down to the ankle, stop there. But this typically is bilateral, it's symmetric, and this is not symmetric. So puzzling. So, in vascular surgery, we try to look one level above for all the med students out there. If the patient comes complaining symptoms on the thigh, you need to look in the pelvic area. If it's in the lower leg, you need to look in the thigh, etc. Normally is the way we start our investigation. So I decided to do the alternatives, reflux venous lupus ultrasound, which I don't think has any point after the ablation they've done, and that was recent, or in tomography, computer tomography of the abdomen. So this is it. And I want you to pay attention here. It's coming from the chest, of course, coming down into the abdomen. You can see the white circle is the aorta coming into the abdomen. And then the first point that I pay attention is right at the crossing with the left common iliac vein, right there. That normally is what causes May-Thurner syndrome. Okay, that is a compression of the right common iliac artery over the left common iliac vein, but doesn't seem to die there. But look at what happened on the left side. We can see the iliac artery going up in white right there, and then there's the left common femoral vein close to the inguinal ligament, and look at what happens to the left common femoral vein. It's completely almost obliterated by this external mass that is right there. That black area around the artery, the white circle, is what is compressing the common femoral vein. What is it? Stay tuned, because it is a problem with this setting. Why? From the clinical standpoint of view, you are going to have to make a decision. So what are the alternatives we have now as a vascular surgeons with this? We have an open exploration. We need to open that groin and see what that is. But opening a groin in an obese patient is not easy, neither is free of possible complications, aka lymphedema, lymphocutaneous fistula, all that kind of stuff. So our alternative was a venogram or an MRI. So I went ahead, of course, for a venogram. So this is the posterior tibial, one of the posterior tibial veins on the left leg. This is the popliteal in normal anatomy. You can see the difference now if you remember the previous case, how the other one is not normal at all. This is the femoral vein. And right here is the femoral vein into the common femoral vein close to the lesser trochanter. What happens there for all the students? See how the contrast doesn't continue proximally into the pelvic area. Seems like it fades away when it shouldn't be that way at all. So the next slide is going to show what we found on the CAT scan, of course, this compression with this very almost string sign of the common femoral vein that reopens in the external iliac vein, and then it has a normal central circulation. So
one thing you don't mention, sorry, I don't want to interrupt you.
No, go ahead.
If you remember on the CT scan, the vein is actually it was either the common or the distal external iliac vein is very dilated as well.
Yeah, we can see it again. That so. See, I can stop it here if we. So here is the aorta, of course, that's the vena cava, and goes into the bifurcation. There is no major compression, compression really, with the common iliac vein, and then it's coming the area that you are questioning, Jean.
Yeah. And you can see it there, right there. So
right
you see
here.
it just relative to
Look
the
at
other.
this.
It's huge.
Look at this. This is the external iliac vein, possibly right at the junction with the internal iliac vein, right here, right?
Correct.
Right here is where. So you can see here the is massive. This vein is massive, and then goes up and goes to this
normalizes
area.
for a period before it then becomes a string sign.
But yes, let me ask you a question, Jean, here. In this area that you are concerned about, when it's big. Do you think part of it also is because the cut of the CAT scan that is coming up and might be longitudinal?
So I thought that. I looked at multiple different views.
Okay.
No, it's real.
Okay.
The interesting thing though is, I don't know if it has any impact on the overall physiology. I don't know if it's a post-stenotic dilatation, but you have a segment of normal external iliac vein before you see this, and after after the stenosis. So it's a little perplexing.
In that's, I'm not gonna say, I was very well. I mean, I saw that was big, but. And that's what I check here, because maybe there is some May Thurner component there, but it's not. But what is disturbing is this darn thing here.
Yeah.
What is this black component here that is compressing it's almost obliterated. That's where the string sign is. Correct. So what I did is that Venogram, and if you can see here in these images that I was showing you, this stenotic area is right where the hip is. You can see the hip right there, the head of the femoral head right there, where it is this stenotic area. I know the literature says, and I know all the people said that now you can put stents across joints. I'm old-fashioned. I'm not quite. I can embrace that quite yet. So what I did was, the only thing I could try is see how this will respond, knowing full well that it wasn't going to work. Right. But and it didn't, of course. You can see the wire there going through it. Now, one thing I want you to see, the young guys, is in the last picture right here on the right, you can see that there are two access points. I don't know if you noticed. There is one that is coming from the posterior tibial vein that injects the contrast, and the one that is coming that got the balloon. Why? For two reasons. Because there is it's difficult to find a balloon long enough to get in there in a comfortable way. And second, because this balloon requires 6 French sheath, and typically that's a little bit beyond what the posterior tibial vein can manage. So I had a different access. So it didn't do anything. I did a percutaneous biopsy with a 22 gauge needle, and it came back as a very generic chronic fibrotic adipose tissue. That's all that the pathology report came back. Now what?
Well, so as you know, I saw her last week, and I think certainly there's some extrinsic compression. That much we can agree on.
Sure.
Right?
Yeah.
Intrinsically, the vein is normal. That's why your angioplasty didn't work.
Correct.
Because you were just going to push whatever was compressing it and push that aside, and it would bounce back. I think at least we merited kind of understanding what this I don't even want to call it a mass, because it just looks like a fatty space in there. What exactly that role plays in this, and understand exactly maybe what it is. So we did order an MRI, which unfortunately has not been done yet.
I checked it out
I was
today.
hoping we would have it for this, but it hasn't been done yet. And maybe we can differentiate that. And if we can, as a surgeon, you want to take it out.
We got to cut.
But the problem is, as you said earlier, this actually dovetails down into the pelvis.
Correct.
And so the stuff in the groin, already you have a healing problem there. The likelihood you're going to get this whole thing out is probably pretty difficult. She's not a small patient.
Yeah.
And I agree with you. I think every time we do, whether you do a central venous bypass, whenever you open the groin in a venous patient or a lymphatic patient, wound healing is your number one enemy.
Correct.
And she's quite edematous on that side.
Yes.
And so that puts you at even higher risk, right? So it is definitely something you have to ponder with a little bit of care, and go forthwith if you're going to go from the surgical aspect. And knowingly speak to the patient. You're likely to have a wound issue and this and that, and I think those are important discussions to have.
Absolutely. As you know, I just came back from I went to the International Vein Congress in Miami. That is a very interesting meeting, and following all the HIPAA regulations for all you guys out there, I did ask about a couple people about this case, some of the experts, and some of them actually were puzzled. They said, well, I don't know what else to do there. I said, one of them says, well, what about if you stent it? If you just stent it, and see what happens. I said, well, as you saw in the previous case, I'm not afraid of stenting. The problem is in the joint. And I'm afraid, I don't know, do you have any experience putting crossing the joint?
I'm not like super shy about it.
Okay.
I think if I can avoid going across the joint, I do. But I think some of the things you have to think about, particularly in my opinion, on the more non-compliant stents, the ones with more radial force, I think fracture across that inguinal ligament is a real thing. And so I don't know that I would trivialize it. If disease does extend in, I've done it pretty regularly, I would say. Yeah. But certainly it's something you think about. You're right, because the teaching is classically not to cross the joint.
Yeah, I know. But and then you have all this technology we talk about advancing, and now you can cross. You can. I mean, it's another cliffhanger that we are going to leave you with, and of course we are going to update you in the next available opportunity what happened to the two patients, because the objective is not a cliffhanger. The objective is to learn, and that's what I think all this is being put in place to exchange information worldwide and learn from each other.
And I think, honestly, if some of the viewers have any comments to this and maybe suggestions and maybe even have encountered something similar. By all means, I think it would be great to hear from you and get some comments on the case, because I think these cases are a little bit challenging. I think certainly the first case that Ulises presented, I think we went pretty far and beyond what the norm would do in venous disease. We have gone primarily minimally invasive today, and I think it is what is attractive to patients, but I think sometimes we have to consider other options, and I think we're doing this in both of these cases, and there are good examples of that you have to think a little bit outside of just your standard therapies.
Absolutely. You have to, because if not, you are very limited.
Right.
All right, your turn, my friend. Go for it.
Okay. So, once again, I'm really grateful to Ulises for having me here. I have two cases that we saw recently, and it's not because they're so difficult a case, but they present two similar problems and two different approaches to it. I think today we have a lot more venous-specific tools, and I think it's really changed the way we start thinking about venous disease. In this case, we're talking about thrombosis, and I spoke about thrombosis last time as well. As you remember, we talked about vena cava filters and so on. But I think how we approach particularly femoral popliteal disease, I don't think it's trivial, particularly the popliteal vein. I think the femoral vein probably can take clotting and can take just being anticoagulated. The popliteal vein a lot of times can't. And so I'm presenting two cases here that have popliteal. The first one has also some other more extensive clot, but let's go through this real quick. And I really want to get some of Ulises' input. He's never seen these cases, so this is a first for him. The first one is a 70-year-old male who had a history of oral cancer, was being followed at MD Anderson, also had a history of a CABG. He had a left leg DVT in 2016, which was a provoked DVT with a PE. And at that time, he had a left iliac vein stent, which was with a wall stent at the time. If you remember, at that point, we didn't have venous-specific stents, so this was kind of the standard was a wall stent. And he essentially presented to the emergency room with complaints of left leg pain, edema over about 2 weeks' time. He was last seen at MD Anderson for his clotting disorder by his hematologist. And at that point, he had actually stopped working and couldn't afford his NOACs anymore. And he ultimately decided to go off a lot of his medications, particularly since he had, it's a little bit, I guess you could say, a consequence of COVID-19. He stopped teaching, being afraid. He was sort of obviously towards his retirement anyway, but didn't want to teach and didn't want to be exposed to the COVID-19.
So I'm sorry.
Yeah.
So he had the stent put in 16 on the, I guess, for May Turners or
for May Turners,
okay.
correct. Yep.
And all right. And
you'll see the stent. And I think again some of the things we want to comment on. So in this case, he's approached from a prone position, and we're accessing his lesser saphenous vein going into his popliteal vein, and you can see what that looks like. Obviously, there's clot throughout there. He's somewhat collateralized, but obviously he's very, very impacted by this. Then we come up to the common femoral vein, which you see there at the lower end of your picture, and he's somewhat, but not very well collateralized up. Obviously, you may not be able to see his stent, but his stent is obviously not visible because it's completely occluded. If you were to be able to see the stent, you'd see the front end is completely cinched down. And the more proximal end of the stent is wide open, as you would expect it to be. We actually got through the stent with relative ease. This is after already having passed the penumbra. So we did this thrombectomy with penumbra, and honestly, most of the time I go up and over. So I would have gone from right to left. And the reason I do that is primarily so I can get the clot clear of the popliteal vein. To me, it seems like a very important element, and the second case actually shows you exactly that, and we can talk a little bit about approach and why. So here you could approach it also from the neck, I think, and come down. I don't know, maybe you can comment on that, Ulises, whether you think that's valuable.
Coming from the neck?
Yeah.
Absolutely. I mean, if I personally like I learned from somebody that does a lot of this, Mark Garcia in Miami, that he likes to start all the way to the posterior tibial, and to try to clear the entire popliteal, because as you know, in vascular surgery, inflow and outflow are key to keep the flow going.
Correct.
So if you have still some debris or leftover in the popliteal vein and you don't clear that, then I think the chances are that probably will re-thrombose faster. Now, up and over is obviously a good technique, and coming from the neck is just straight shot, right?
Correct.
Instead of going from the right groin, the common femoral, go over the bifurcation and turn around in the vein, because the angle is different, is a little bit more cumbersome than even with the artery, with the aorta. So I think is coming from the neck is fine.
And so we've done some of those more recently, and they've been primarily patients that have had stents in already, that we either had to have a better access to, or we couldn't get around because the stent, obviously, a lot of the wall stents have always jutted out into the vena cava, and so it's almost impossible to get around. So in any case, this is ultimately what we got out from that. This is with a penumbra system. We used, in this case, we used both the 8 Lightning and the 12 Lightning. The Lightning obviously just reduces your blood loss significantly, but obviously this is very impactful.
Yes.
And this is what it ends up looking. We actually extended the stent proximally and distally with a Zilver-Vena stent. Hopefully he stays on anticoagulation. Obviously, he's at risk for failure if he doesn't.
Of course.
But the key thing for us here, I think I'd like to discuss with you is, obviously, because of our access point, we can't clear out the popliteal vein.
Correct.
His recovery was actually somewhat slower. And to your point, so the follow-up ultrasound showed pretty much clear throughout. There was still some partial thrombus throughout the femoral vein, and the popliteal vein had a little bit more of it because we actually didn't do any work down there. How critical do you think that is?
Well, I think it's important, because number one, the physiology and the venous system, as you know, the blood flow is way slower.
Right.
And that's one of the, Virchow's triad, right? The stasis. So it's way slower. So as soon as you have some other obstacles, it's gonna increase the chances of rethrombose or increase the chances of post-phlebitic syndrome. That's another different topic. But yes, I think it's critical that if you have the access and if you have the technology and you have the means, to clear up as much as possible of that leftover thrombus. Now, it's true also that in some of these patients, it's difficult to get into the popliteal vein because into the posterior tibial vein, because it all depends the habitus of the patient. If it's a 300-pound patient, it's difficult. But if you come from the neck, and that's what the beauty of this, if you come from the neck, not only you get into the left iliac vein easier, even if the wall stent is protruding into the vena cava, but the valves are already probably gone, and is relatively simple to go all the way down and clear it. But I don't know. What do you find there?
So it's interesting. I'd like your thoughts on this because, so one of the things we've been seeing in a lot of these patients post-operatively, so we've had a pretty good series of patients now where we're very aggressive at trying to clear the popliteal vein. To me, very important, as I mentioned. You made a couple points in your first two cases that I really appreciated, because today, now you don't really treat much arterial disease anymore, but pedal access is a common term, right? Today, for arterial, pedal access is an everyday thing, right? Why is it not for venous disease? Most physicians who treat venous disease don't get pedal access.
Yeah.
And I understand that. It's the same process, and there's enormous value in doing that.
Absolutely.
Right? So one is your trajectory.
Correct.
So if you have a hard time getting down, for those of you who haven't done a retrograde approach to the femoral popliteal vein, it's actually not as difficult as all that to get through the vein. It's fairly easy. I think it's dilated because it's got clot in it. You can usually get through it pretty easily. Sometimes you can't. And then coming from a pedal access, at least you can either snare the wire or you can at least have a trajectory of where you're going. And that's served us extremely well. So when you brought that up, I was actually pretty excited because it was going to feed into this pretty well.
Yeah, absolutely. No, that's true.
It
is clear. I mean, when you do an arterial study, you don't stop in the popliteal artery, right?
Correct.
I mean, you go all the way down and see the dorsalis pedis and even the arches, and see what is going.
Yeah, I think there needs to be a return to the venogram.
Yeah.
We for years I really didn't perform many venograms. Unless I knew I was putting a stent in, I thought there was Maytherners or whatever it was. But I think you're absolutely right. The venogram gives us a very dynamic appreciation of what's going on. How is the leg draining? Where is it draining?
Yeah.
Is the profunda open? Is that where? Because for a popliteal vein, mostly it's going to drain. If it's open, it's going to drain to the profunda if the femoral vein is, right?
Correct.
And you like to see that.
Correct.
You like to see that drainage. You don't necessarily need to open up the femoral vein, but I think you have to open up the popliteal vein.
Absolutely. And as you saw in my cases, my threshold to the venogram is pretty low. I'm not.
No, I know about you. I've actually changed my practice because of you.
No. But the thing is, it is important. It's important to see the entire, flow, because there is a lot of stuff that we miss below the knee that is important.
So let me ask you another question. You said earlier, because I actually do listen to you, even though usually you tell me I don't, but I do listen to you. It was interesting. You said you were afraid of, or at least you would consider not putting a 6 French sheath into the posterior or a tibial vein.
Posterior tibial vein.
Right.
Yeah.
So tibial veins are paired, right? So you have really 6 tibial veins.
Correct.
Right?
Correct.
So would you ever consider, so Penumbra has a new system that's 7 French.
Yeah.
Would you consider putting a 7 French sheath and then going up and treating the popliteal vein? That I've thought about it.
Sure.
Haven't done it yet.
Sure. Well, let me tell you this. The comment maybe was impromptu, because all depends the size of the vein. The first case that I presented, that's a nice posterior tibial vein. It can accommodate 7 French very easily and gently.
Right.
But there are other veins that they will shred it to pieces. And yeah, you have 5 more, but doesn't give you kind of the authority to destroy. Yeah. Well, we have more there. So, it's patient by patient, but it's selecting the sheet that you will put in the posterior tibial vein is very important. That's number one. And number two is the length. What are you trying to reach? There are cases that we're trying to stent the external iliac vein into the May Turner. It's not going to reach from the ankle. You need to get another access. So, which, by the way, let me tell you something. The fact that you access the posterior, the lesser saphenous vein to get into the popliteal vein, that I haven't heard many people doing that. I do it fairly regularly because, my work with veins. But it's an excellent access, especially when the patient is anticoagulated.
Right.
It's awesome.
Safe.
The greater saphenous vein, the lesser saphenous vein, to get in there and going is phenomenal.
Right.
It has saved me multiple times from getting in trouble in patients with full anticoagulation, that you try to get to the popliteal vein, you do it that. And as you know, the anatomy and as medical students, the popliteal fossa is empty. There is a lot of space that can be bleeding and nobody knows, right? Until it gets symptomatic.
Right.
So that's excellent. I mean, I really like that.
Well, thank you. So, we're gonna go on to the next case.
Yeah.
And this is a little bit contrast. So as you saw, the first patient was a 70-year-old male. This is a 41-year-old male. I actually, when this gentleman came to the hospital, I was actually out of town. And there was apparently nobody that really wanted to do anything with him, and he wanted to stay in the hospital and was not doing very well. Anyway, he has a history of Achilles tendon surgery, shoulder surgery. He's a retired professional baseball player. Now teaches a big league here in Houston, super guy actually. And he essentially had about 3 weeks of shortness of breath, left leg edema, and pain that was lasting a few days up to the admission, okay? Now he had no recent prolonged travel otherwise, no recent trauma, but he was using testosterone injections every other week. And I tell you, it's interesting here, the last probably year, I've seen a number of these patients with testosterone. Testosterone seems to be used so liberally these days. And so, we have seen both arterial and venous thromboses in these patients, and it's not to be taken lightly.
Yes. And let me make a comment there, Jean, for all of you out there that you have a male patient that comes otherwise healthy with some even superficial thrombophlebitis. Doesn't need to be a DVT. Dig a little bit, and you will be surprised how many of them are taking testosterone supplements. Absolutely. Yeah.
So the interesting with him is, so he had come in on a Thursday. I was out of town. I was coming back on Saturday, and they kept walking him around, and he had true venous claudication, which is surprising given his iliac vein is wide open. As you can see, we've gone up and over from the right side to the left side. And here you get a picture a little further down. Obviously, a substantial amount of clot that is at the origin of his profunda vein as well, and then extending down the femoral vein. And then here you see what it looks like down at the knee. Wow. Pretty dramatic, actually, right?
Yeah.
So if we then take a shot of, after we cleared out, you can see the popliteal vein down below. I think pretty dramatically cleared of clot. A lot of those collaterals that were very dramatic are now gone.
Yeah.
All right. And this is kind of what that looks like up the femoral vein afterwards.
Wow.
And this is just with the penumbra thrombectomy. We didn't do anything else.
Wow.
Now the curious thing, so I've had a few patients like this. This guy came back, had an ultrasound, valves intact.
Wow.
And no clot in the popliteal vein. To me, that's a game changer.
Of course, it is.
Oh, seriously.
It is, because the progress is going to be completely different.
So, I can tell you this, and we're telling our viewers this. I treated one of my partners back earlier this past year, and he was probably about 3 months out from his original symptoms upon questioning, because surgeons are even worse historians than patients.
I agree. And worse patients than the patients.
Yeah.
We are. Yeah.
So, but I was, obviously he's a colleague, but we go above and beyond, and I really spent a lot of time trying to clear out his popliteal vein, and we ultrasounded him back in January, so about 4 or 5 months after the procedure, and same thing with him, clear, valves intact.
That goes to tell, all the stuff we don't know. We take because you and I train and we learn that the inflammatory effects from the thrombus in the valves are immediate.
Correct.
Correct. If you don't lyse that clot the moment you see it, the chances of recovery are very negligible.
Right.
It's not.
Right. And I think the tools now, we were talking about specific tools for venous disease, although this is a thrombectomy device for everything, but it's very well suited for venous disease, and obviously the big 12 lightning catheter, the 12 French catheter, really gives you an immense power as far as your ability to remove clot. And I think it's safe.
It's a great.
These patients go back to the floor. They're doing well, and there's. I think in my book, there's no reason to not go after this today.
Absolutely, and there is no thrombolysis. The patients that are at risk of bleeding,
100%.
You are not using thrombolytics.
100%.
Great cases, Jean. Thank you so much for joining us. We are running out of time. Our friend here is telling us that they are gonna cut the streaming soon. So I want to thank everybody from watching. We have one more show this season before there is going to be a summer break. So the next Joan Lore is going to be here talking about chronic vein occlusion. So I encourage you to be tune up next month. In the meantime, in the fall when we are back, let's try to update these cases, see what happened. Yeah. But I want to thank everybody. I want to thank you for coming and helping me again in this show, and all the team here, Tyree and George. And God bless you, and we'll see you next month.